All right, guys, we're going to start off looking at the syllabus and hopefully getting most of your questions answered there. And then we'll kind of get into our lecture content. Just so everybody knows, the way this is set up, we'll use this link for any class I'm doing, and then Dr. Mordecai will have her own link for any of the classes she's doing. If you forget where it is, you can always just go back to the announcement and pull it up there. Are you guys able to see my screen okay?
Yeah.
Okay, cool. So we're just going to kind of look through the syllabus together and answer any questions you guys have. Class will be Tuesday, Thursday. It says 9 to 11:30. The reality is we'll probably be done by 11, if not before, every day. As a result of that, you'll see that there is some extra outside of class work, whether it's the Maverick modules or the reading quizzes, a lot of different things there, or like the Anasoft cases. Reading wise, in response to some feedback from you guys, there will be reading assignments and essentially you're going to have to provide feedback on that by virtue of reading quizzes. So some of those quizzes will be based off of articles. Some of those quizzes will be based off of Miller's. So sorry if you don't like to read. I would figure out how to change that. So looking at the syllabus quiz is there. It's open through Sunday. It's 1 extra credit point. You will have 3 exams from us. They are all building on the one before them, so they're all cumulative. Exam 3 will be cumulative for everything, as well as some content. So if you'll just kind of pay attention to that. The Maverick module exams, partly, I tell you guys this all the time, don't be the ones that have a rule named after yourself. But the class last year kind of messed around and procrastinated on their Maverick modules. If you don't complete the Maverick modules with a passing score, there will be a secondary assignment. Don't wait. Those modules take a significant amount of time, probably 40 to 80 hours to do appropriately. With that being said, when you look at the calendar, you've got quite a bit of time there to do those. So there's no reason we should be waiting. There's no reason we should be rushing. And we can see in real time how you're doing, how much time you spent there. So please don't be a disappointment. For symposium, we're going to be doing some high-risk, low-volume cases in the sim lab, so there are care plans for each of those so you guys can kind of prepare. At the end of the course, there will be a clinical pharmacology exam. One of the things people have kind of struggled with when they get to clinicals is pharm stuff. If you don't get at least a 90, you will have to take a secondary assignment, and you will have to take another pharm exam before you start clinicals. If you're unable to pass it at that time, you will start to use vacation days until you're able to pass the exam. So let's not do that. It's pretty straightforward, and this is what you're going to be doing for the rest of your career. So let's make sure we do well on that. There's some Anasoft cases, and then, as I said, the assigned reading quizzes. We'll kind of go through this schedule itself. Has anyone had trouble getting into Anasoft? I know you guys have used it before, but has anybody had issues this time? They went through and did an update.
No.
Okay, cool.
No issues.
If you do, feel free to shoot me an email. As far as the schedule itself, this is us in week 1 right now. You've got a reading quiz, the syllabus quiz, and an Anasoft case to do this week. Next week, we're going to go over burns and hospital-acquired infections. Week 3, you'll have another reading quiz and another Anasoft case. Week 3, we'll kind of finish up all the content for exam 1 with obesity. Um, After that, you'll start into exam 2. So for clarification, obesity will be on exam 1. When we move into geriatrics, that will be the start of the content for exam 2. Week 4, you'll have patient positioning, and then you'll have your exam 1 on September 16th. Week 5, skip and iris, as well as some PACU management, another Anasoft case, and reading quiz. Week 6 will be acute pain, and then the start of Unit 3. So acute pain will be on exam 2. Exam 3 will start with immunocompromised patients. And then week 7, we're going to go over general surgery, gastrourinary surgery, and GYN surgical stuff. And then you'll have exam 7 on October 7th. Week 8, Dr. Mordecai is going to go over PONV and chemotherapy. And then you'll have exam 3s on the 21st. After that, you're going to transition into the Maverick content. So the way this is set up is that's basically all your classwork. So we won't have actual classes. You'll be responsible for going through and doing the Maverick modules and then attending symposium. And I'll talk about symposium a little bit more after this. After we finish symposium, we come back and we have a little break for a minute to let you guys kind of recover. And then Dr. Schaefer is going to be talking about clinical preparation and Typhon, so you guys can get ready for that. After we wrap up with that, we'll transition into pharmacology. The pharmacology stuff will be available right after we finish up symposium, and then we'll come back and move into finishing up pharm and taking the pharm exam on December 4th. Any questions about that outline?
Dr. Cornelius, I have a question.
Yes, ma'am.
Hi, good morning. So I noticed on the syllabus there weren't like specific dates for the reading quizzes. I know that the reading quiz 1 is up and has a due date on the assignments, but what about for the other ones? Are they all just
They'll
due
basically
on Tuesday?
usually they'll be due on, well, obviously they'll be due on the date that it's scheduled there, but it's usually Sunday at midnight of that end of that week. So
Okay,
like
all right.
reading quiz 1 is due on August 31st at midnight. Reading quiz 2 is due on September 7th at midnight and
Okay.
whatnot.
All right, sounds
So,
good. Thank you.
yeah, we try to give you the whole week to do it. Other
Dr.
questions
Cornelius?
about this? Yep, I can barely hear you.
2 questions. Can you hear me now?
Yeah, it's better. Thank you.
Okay, great. First of all, for the care plans, did you want us to use the old outlines that we've used for their classes? And if so, are you going to provide us fake patients so we can fill out like the hemoglobin, the fluids, and all that stuff, or are we leaving them blank?
You cannot. So two things. One, you don't have to follow a specific format for the care plans. Depending on which clinical site you're going to, everybody kind of has their own layout. So from that standpoint, I don't care what format you put it in. I did include some examples for you guys. And then the second part of that is I'm more worried about you understanding the case factors versus the patient factors. So, what do you need to know as far as positioning, medications, complications of the surgery? A lot of times the patient is the easy part of it. It's the case itself that's very difficult to do and understand. Does that make sense?
Yes. And then the second question was, does that mean we can't access Maverick modules until I think like week 8 or 9?
No, I'm going to post the Maverick content for you in just a couple weeks. I just wanted to get through everybody understanding what's going on. Because when you guys go through and take those quizzes, it's a one-time thing. You can't go back and retake it because you did a poor job. You will have plenty of time to work on the Maverick modules. Just make sure you understand that content thoroughly before you start taking the exams. But it'll be posted well before that time.
Okay, great. Thank you.
Yep. Any other questions about the syllabus or stuff? Okay. As far as symposium goes, I'm just going to kind of review the schedule for you guys that week. So you will need to get here Wednesday night because on Thursday there are a variety of activities. Some of them are fun, some are not so fun. So Thursday, you'll be responsible for completing your health clearance. You'll be responsible for making sure your ACLS, PALS, and BLS is current. You don't have to do it here. You just have to make sure you have a current card for clinicals. Okay. So however you want to achieve that, I know some people are kind of working this semester If the hospital takes care of you, that's great. Just make sure you have an American Heart Association class so you're good to go for clinicals. If you expire like a year from that, it's okay as long as you have a kind of a mechanism in place to recertify it. That's not a big deal. We try to make it pretty quick and easy for you. It's $225 to do all 3 classes. There will be some pre-course work and the written test, and then that day we'll do some scenarios. So like I said, we try and make it as easy and painless as possible. But you do not have to do it here. You just have to do it. Thursday night, we're going to have a Halloween party get-together sponsored by one of the anesthesia groups. So generally, we try and get groups to come in and sponsor events in the evening. So it's a happy hour type event. Not necessarily full meals, although some of them kind of approach that. But there's hors d'oeuvres, free drinks, and they usually rent out a restaurant or a bar or a venue somewhere for you guys to kind of get together and relax. Because, you know, everybody's been together for a year and then you guys all jetted off this semester. So it's kind of nice for us to relax and have fun together. So we try and do one of those events almost every night of Symposium. So that's Thursday night. Friday morning, we'll start Symposium bright and early at 8 o'clock. The schedule for Symposium will be coming out a couple weeks beforehand as far as what rotations you have and whatnot. Basically, the way it works is we have a series of rotations here through the program, and then the group will be divided up in half, and half of you will do Maverick all day Saturday, half day Sunday, and then the second half will do half day Sunday, all day Monday. And that'll be on campus here at Lou's place, so you won't have to travel for that. But like I said, part of that's dependent on you completing all the online modules ahead of time. And then everything else is kind of here on campus in different places. We'll have lunch every day at Martin Center. We have some speakers. There's a ton of employers and vendors that come, so lots of people to talk to if you're interested in kind of what the job future holds for you. We have some guest lecturers that come and explain all sorts of things from the latest and greatest in cardiovascular monitoring to CRNA practice in Texas, what have you. So it's a pretty good time. I honestly, and I tell everybody this, I think it's probably the most fun in the program. Any questions on that? You should be able to fly out Monday evening. The last session finishes at 5, and I won't be able to tell you if you're in that last session until we get a little bit closer. So if you schedule a flight out, just make sure it's late enough that evening that you'd be able to be here till 5. If you're driving, it's obviously not an issue. And then if you just want to be on the safe side, you can leave on Tuesday. All right. Any other questions? All right. I'm going to hand it over to Dr. Mordecai to go ahead and get started with our content for today.
Okay, perfect. Thanks, Dr. Cornelius. I'm going to share my screen. Hopefully this pops up for you. I'm going to pull the PowerPoint up. Can you guys see this?
No.
No.
Okay, let's see. Share.
Yeah, the screen share is weird for some reason.
Is it showing on my end? How did you pull it up? I hit share and then under presenter mode, I hit content. Oh, let's see, screen. Does that help? You see it now?
We can see it.
Okay, great. All right, we'll start from the beginning here. Put that to the side. Okay, great. All right, so this is our lecture on conflict management in the operating room. It's a lot to do with communication and effective communication. So just to go ahead and run down like what our goals are in this lecture, what we want to do is facilitate a positive transition for you guys into the anesthesia clinical setting, because you've been in didactics for so long and it's been a long time since you've been in a clinical setting and you've actually never really been in the operating room as a resident nurse anesthetist before. So this will be a new ball game for you guys. We want to define your role in collaborating with the operating room team, because now you have an MDA or an anesthesiologist that you're working with, and then you're learning, but you're also doing a lot of things with your CRNA, and you've got to learn to communicate well with your scrubs, your circulators, and all the members of the team, pre-op, PACU, everybody. You want to have very effective communication skills to kind of smooth this process for you, and to optimize your patient's care. So we're going to identify the areas of possible conflict. These are things that throughout the years we've encountered and learned to diffuse. And so we kind of want to give you guys a heads up on the kind of things you're going to be seeing and dealing with. We're going to discuss how to prevent conflict and then how to resolve conflict in situations, because you can't always prevent it. And then we're going to discuss our team building practices that facilitate a peaceful and collaborative work environment throughout the day, so we can all enjoy our jobs doing anesthesia and working with our team. Are you guys getting all these pop-ups that I'm getting?
Yes.
That's okay. I'll keep me a minute. All right. So talking about getting established in the operating room. All right. So realize that first impressions are extremely important. Everyone's kind of aware that you guys are about to show up for clinical. And so first impressions are very important. You want to show up eager to learn and very organized. This is going to set the tone for establishing your reputation. And so very early on, your work ethic is going to become apparent. Are you going to be the one that shows up late and you didn't look up your patient? Or are you going to be the one that shows up early, has everything ready, has your patient looked up, has the type of surgery looked up, knows the kind of medications you're going to be prepared to have drawn up and ready, and then have extra time to pivot if things change, or maybe your CRNA wants to go a different route. Okay, so be prepared when you show up. And when you meet people, you're going to be meeting so many people the first few weeks. So have a very strong introduction for your peers, your coworkers, and your patients, so that you can be memorable. They can get to know you and hopefully learn to trust you early on. All right, so you're going to introduce yourself first and last name and your title to your patient. So you're going to say, hi, my name is Angela Mordecai. I am a resident in the program of nurse anesthesia at Texas Wesleyan, and I'll be doing your anesthesia. And you're going to answer questions. You're going to really help clarify your role to your patient, so that can build confidence in who you are and what you're doing, and kind of minimize the unknown. Make eye contact when you're talking to people, whether it's the CRNAs, the MDAs, anybody that you're talking to. You want to present yourself as confident and ready to learn. And then you always want to show up prepared. As I said, before your case, you're going to know your patient. You're going to have the night before, your cases will be posted, and you should be able to look up your patient and just know the basics about them, whether they have diabetes, thyroid problems, a cardiac history, those kind of things. And then if not that, you're definitely going to know your cases beforehand. Depending on whether or not you have access to patient information may vary depending on your clinical site, but you should definitely know what surgical cases you're doing, and being able to have time to research beforehand what you're going to need to know and be prepared for the specific type of surgery. Okay. So for instance, if it's a carotid endarterectomy, you're going to need to know that you got to have Cardene and an A-line ready to go that morning, on top of just your basic general anesthesia setup. You always, as I said, you want to be on time or early. I can't emphasize that enough. You guys probably aren't used to getting up at, 5 a.m. or sometimes earlier, depending on how big your case is, and getting there. But don't oversleep. Don't forget to set your alarm. I always set 2 alarms because I was paranoid about missing an alarm. You need to be there, and you need to be there early. Get used to communicating with everyone. So not just your CRNA, because it's not just the 2 of you in the room. Everybody works together. So get to know everybody. This includes your turnover team, the janitorial staff, anybody, even administrators. You want to get familiar with everybody, so that way it'll make your lives better and makes the whole day flow better. All right, so what are some common issues in the orientation period? So when you guys first get there, you just don't know who is who because everyone looks the same. Everyone's got a hat on, a mask on, the same color scrubs. So you're going to have to work hard to learn names and identify who people are. You want to get familiar with all of the staff, who are the CRNAs, who are the other student resident nurse anesthetists, because you may have multiple schools at your location. Who are the anesthesiologists, who are the circulators, who are the scrub techs. And so once you get familiar with that, it makes the whole day flow better. You can communicate easier. You can get things done a lot more efficiently. Learn names. Again, make eye contact. And it really helps if you say the name back after you meet somebody. So, hi, John, my name's Angela. And so that will reiterate to them who you are and to you who they are. Another issue is some of these clinical sites are huge. So in the very big facilities, places like Bumsey and Harris, where there's multiple towers, it's going to take several weeks to really remember where OR 7 is, or, where the supplies are located. So if possible, early on, try to make a map and memorize, if you're in one of these big, massive locations, where things are, where the supply rooms are, how sometimes operating room layouts aren't intuitive. Sometimes it'll be like, here's this hallway is 1 through 5, and then it'll jump, and this is OR 12 to 16. So if there's weird things like that, try to make a note of that. Again, supplies may be located in places that are a little obscure. Sometimes you have 2 or 3 different locations for supplies. So sometimes you may go to one supply room and there might be endotracheal tubes and circuits, but you may have to go somewhere else to find nasal cannulas and IV start supplies. So when you have breaks in time between cases, utilize that time to familiarize yourself with where different things are located. So walk into the storage rooms and just kind of scan through and locate where things are. And likewise, in your operating rooms, most operating rooms these days have Pyxis in them. So you really want to go through the drug cards. And even if there's not a Pyxis, there's going to be a drug box or some location where the common medications that you give for every case are going to be located, and emergency medications. So take time to scan through those bins and boxes and drawers to know where your drugs are located, where each drug is located, especially your critical drugs. So your uppers, your downers. You don't want to be fishing around for atropine when your patient heart rate drops to 30. You want to know exactly where it is so you can pop it, draw it up, dilute it, and do your thing as quickly and efficiently as possible. So that's very important. Another thing to make your life easier, right off the bat, the first few days, you're going to have probably 6 or 7 different passwords, lock codes, phone numbers to the blood bank, numbers to the pharmacy, numbers to the ICU. Store them in your phone, put them in your notes, put them where you have quick access, so that way it doesn't take away from patient care. If you lose one of those numbers, that's going to be a time suck, and you don't need that. So make it a note to store those where you have quick access to those kind of things. So other common issues that can occur. Okay, so every CRNA that you work with is going to have a different way of doing things, different preferences. And you will learn that one day you're going to have an amazing day with somebody and you're going to feel like, I totally get it, like I know what I'm doing. And then next day you're going to work with somebody that's like, you don't do it that way. That's not how you do it. And you're going to feel so dumb. So just know that that's a natural part of the process. It's, working with different chefs, have different recipes, and they all making the same thing, right? So we're all doing anesthesia. You guys know that I teach you guys to intubate. I teach my residents to intubate without a stylet. That's just something I do. But then you're going to work with somebody that doesn't want you to even try without a stylet. So just be respectful of what your CRNA wants. You're there to learn their way. And when you learn everybody's way, it helps you form your way based on multiple different experiences. So view this as a positive thing. When you get to learn all the different techniques and everyone's different preferences, it helps you have a broad understanding of all the different ways to do things, and helps you define what your way is going to be when you graduate. Some CRNAs are going to want you to place all of the monitors on in pre-op. So things like a pulse ox, a blood pressure cuff, the EKG leads. And that way, when you roll them into the operating room, all you got to do is plug it in, and it's time saving, right? Other CRNAs don't want you to do that. They want you to get the patient, and we'll put all that in the operating room. You may have a lot of CRNAs will want you to have everything for the day set up. If you have 3 cases, have 3 sets of syringe drawn, or maybe not drawn up, but unpackaged and put together, ET tubes for every patient, all the things that you're going to need ready to go. In that way, when you're doing a case, you don't have to take time and attention away from your current patient to set up for the next case. You may have it already ready to go first thing in the morning and stored in a drawer and kept clean. So that way, when your patient's awake, you can take care of your patient, give all your attention to your patient, take them to recovery, and then come back to the room and be already prepared for the next patient. But then you may have a CRNA that doesn't want you to open anything unnecessary, because there's always a chance that cases can move, and you may lose your next case. You may end up being done after your first case and having to go to a different operating room. So again, ask your CRNA what their preference is on these kind of things. Some CRNAs want to give everybody IV Tylenol unless it's contraindicated or they've already had it. That's a very common thing to do, but it's not necessarily everybody across the board. Precedex is the same. Precedex is a lovely drug, and people love it, and some people just don't want to bother with it because it's expensive and it's not always necessary, right? So something to clarify whether or not your CRNA is on board with giving that medication to smooth the wake up, or as long as you have a rationale, people are pretty open to those kind of things, as long as you have a reason for what you want to give. A lot of CRNAs want to give the first, after you give the Versed, just leave the IV fluid wide open, start making up for that volume deficit. And some are going to be more precise with how much fluid they're going to give. And it also is going to depend on your patient's comorbidities. So keep all these things in mind. Now, when it comes to reversals, there's the 2 options of giving Sugammadex or giving neostigmine and glycopyrrolate. All right, so both have their pros and cons. A lot of CRNAs prefer, especially for students, to learn the learning curve of reversing your patient with neostigmine and glycopyrrolate. There's more of an art to reversing your patient that way. You're going to have to, you're going to use 2 drugs. You're going to calculate the doses for the 2 drugs, and you're going to give it. And there's, you got to give it slowly and prevent the cholinergic effects of the neostigmine and those kind of things. And then a lot of CRNAs will say, I only exclusively reverse with Sugammadex because it's not worth the side effects of the neostigmine and glycopyrrolate. And the cost risk analysis shows that it's worth it to opt for the Sugammadex. So people have strong opinions about this. Just make sure you ask beforehand and then act accordingly. Some are going to want you to extubate your patient at the end of the case on the operating room table. That's me. I like to always extubate my patient right there. So that way, if they don't fly, I've got my machine, my ventilator, and my supplies right there next to me to re-intubate. However, if your patient's taking great tidal volumes and it's very unlikely that they're not going to fly, it might be beneficial to move them over to the operating or over to the stretcher. And that way, the team's kind of always waiting on, once the surgery is done and it's your turn to wake the patient up and then the team's ready to get the room turned over, it can be more efficient to move the patient over to the stretcher, raise the head of the bed, suction them out, and when they're ready, you extubate, and then you can just roll on to PACU. So just be aware that there's different schools of thought on that as well. So yeah, all of these things I've heard a story about from a student saying, I thought we were supposed to do it this way, and then they were, the next CRNA didn't like it and they wanted it done this way. So I just want to give you a heads up about those kind of things. But overall, communication is key, all right? We know that poor teamwork and communication can lead to frustration and it can lead to medical errors, and we don't want that. And research shows that 38% of anesthesia-related sentinel events are related to poor communication. So this is a big chunk of sentinel events that can be avoided. So an example of this, okay, and this pretty much has probably happened to every CRNA, but what happens is the front desk can make changes and add on cases, and they tell the anesthesiologist, but not necessarily the CRNA, because you're in the case taking care of the patient, and this anesthesiologist is not in the room, not in the operating room. They may be the first person that the board tells, right? Well, then you may think that you're done because you've done a few cases and you've had a built-in lunch break or whatever. So you go to lunch, but then you don't know that the board had added on a case, right? And now the surgeon and the staff are ready to roll back with the next case and they can't find you. You don't want that to happen, right? So what happens in this situation is the anesthesiologist oftentimes thinks that because the circulator gets a heads up from the board. So the anesthesiologist probably thinks the circulator told you because you're both in the operating room together. And the circulator thinks the MDA told you because you're a team together. So this is a communication dynamic that can happen, right? So in order to avoid this, if you're ever going to take an extended break other than a quick potty break, go to the board and make sure that you have the time to do so. And that way you can avoid being a holdup if there's a change that you weren't notified of. Another example, and I use this example because it happened to me when I was very new as a resident. So I had a patient with really low blood pressure, and the CRNA gave me the ephedrine and said, give 5 of ephedrine. And I gave 5 cc's of ephedrine, and I felt immediately like that was a heavy dose. And I looked at her and I was like, you meant 5 milligrams. And she was like, yeah, I meant 5 milligrams. So fortunately, we just turned up the gas and the patient did fine, had, ended up with a pressure of probably 130 when it was starting out at like 80, right? So we were able to compensate and fix that quickly, but that's an error that could have been way, way worse, right? So if there's always repeat when someone says to give something and clarify before you just go ahead and give it, right? Okay, so moving on. Knowing your role, okay? Our focus in anesthesia is different really than you've ever had before. So your focus is going to be on strictly patient safety, airway, their hemodynamics, their analgesia, and maintaining an appropriate level of consciousness for the situation, right? This is our focus and our goal. So when you're a CRNA, you may be delegating nursing roles to nurses respectfully, all right? So now the hierarchy is a little bit different than what you're used to, okay? Your nurses will obtain the consents for you for anesthesia and for surgery. You're not the one filling out the consents and giving it to the patient to sign. And it is a conflict of interest for you to fill out the anesthesia consent and have the patient sign it because you're the one administering the anesthesia. So you need a middleman to perform that for you. So that's going to be your nurses. And then when you're a CRNA, you may ask the nurses to start the second IV for you while you're managing the airway and doing other things. However, as a resident, it's unlikely that you'll do that because there's you and a CRNA, and you want to get as many IVs and sticks and lines in as possible and maximize your clinical experience. But as things progress towards the end, if you're doing a big case and you've got an A line, a central line, and other things to do, you're titrating pressures on the pump, you may ask the circulator to start an IV for you or do something for you, maybe start put on the bear hugger for you, those kind of things. So just know that you're going to be delegating tasks as well. Generally, at this point, nurses are responsible for body fluid cleanup below the neck, all right? So our job is always airway, and we don't leave the airway to clean up tube feeding, colostomy bag drainage, changing out Foleys. We don't mess with that kind of stuff anymore. Just your priority is your patient's airway, and those nurses are more than qualified to take care of the other things. So don't leave the airway. And this is just new for you. You haven't thought about it this way before, but this is your new role. So you want to very clearly communicate with your nurses and the scrub techs, things such as any latex allergies before you bring the patient back so that they can prepare the room appropriately. You want to give the team a heads up if you notice the patient has some bloodborne transmittable diseases, if there's HIV or Hep C or something, or anything that they just may need to be on alert for in case they're going to be in contact, because they are going to be around the body fluids, just, they're going to be near the surgery as well. And any instruments that need to be repositioned for patient safety during the case. So your patient's going to be under drapes, and a lot of times, the lighting may be off, or the surgeons focus on the surgery. And so sometimes they don't acknowledge where the patient's face is under the drapes, and they may put a scope or some equipment just right directly over the face, right? So it's our job to keep the patient's face clear of any pressure when they're supine or in any position. It's your job to keep, basically prevent any harm to their body. And so you need to be on high alert for those kind of things, and let the surgeon or scrub tech know if they're starting to put things in areas that aren't best for the patient. Okay, so when you're in clinicals, you're going to have a clinical coordinator you're assigned to that you're going to meet and you're going to get to know very well. This is going to be your initial main contact person for any facility questions, as well as things like care plans, break protocols, according to that facility, any supply issues. If you're noticing that you're running low on certain things that need to be restocked. I mean, there's other people, but your clinical coordinator is going to be your main contact, and they may direct you to, oh, this person's in charge of ordering supplies, or check with this person for IT issues. But you have a clinical coordinator to be kind of your go-to person for all things clinical. You're going to work alongside multiple different CRNAs throughout the week, and sometimes multiple CRNAs within the same shift. All right. So sometimes you have, one case in the morning, and then that room's done, and you're going to jump into another operating room with another CRNA. And then maybe around, 2:00, that CRNA goes home and they get relieved by another CRNA. So you're going to work with all these different faces until you'll have opportunity to see everyone's different angles on how they like to do things, but you also get to know a lot of different people that way and a lot of CRNAs that way. So it kind of helps in that first month of clinicals. You're just going to be a sponge, learning new faces, learning new names, learning everything about anesthesia. And so it's a lot to take in. Now, some of your CRNAs are going to encourage more autonomy. They're going to guide you through things initially, and as you are capable of doing things independently, they're going to allow that. And others find it more difficult to step back. Others want to be kind of, ultimately the patients are the CRNAs they're the ones with the license, right? And they're guiding you, but it's their responsibility. And so until you prove yourself, don't expect to get like full autonomy. Once you're later on and you become seniors, you may even be sitting your own cases independently, which is the ability to call your CRNA in if you need a second set of hands and those kind of things. Of course, people will check on you regularly, but right off the bat, you're learning and taking in information. You won't be doing things independently. No one's going to leave you right off the bat and expect you to figure it out. Most of our clinical sites, if not all of them, practice in anesthesia care team models, which require a collaborative approach between the MDA or the anesthesiologist, right, and the CRNA. So both the MDAs and CRNAs that you're working with will need to develop confidence in your skill level before your autonomy is earned, okay? Okay, so realize that all of our facilities, and really anywhere that you practice anesthesia, there's going to be a care team model, and this is, or there's going to be an anesthesia care model that's practiced, and this is a billing thing, and so we need to be compliant with the facilities anesthesia practice model so that we can we can make sure that we check the boxes, and we can avoid billing fraud. We're going to do things the way the facility has a contract with the anesthesia group, right? So medical direction is a common anesthesia billing practice in our care team model. And this is where the MDA or anesthesiologist directs up to 4 CRNAs at a time, right? So 4 CRNAs are in 4 different operating rooms administering anesthesia. And for each of the 4 CRNAs, there is one anesthesiologist that is expected to be overseeing or directing the CRNAs. And so for this model to be billed for, 7 criteria have to be met for the anesthesiologist to build for this model, right? So these 7 criteria are: 1, that the anesthesiologist has to perform the pre-anesthetic evaluation and exam, right? So this is what they do in pre-op while you're getting the room ready for the patient. And then the anesthesiologist will provide a note with some of the basic information that he's collected about the patient and what the plan should be. So, they'll probably write general anesthesia. Maybe they write we need a second IV in A-line. Maybe we need a certain type of tube for the case, an oral ray tube or something like that. So they'll prescribe an anesthetic plan. And then the next criteria is that they participate in the induction and emergence and in any demanding anesthetic procedures. All right. So this is a little bit more tricky, right? Because oftentimes we have 7:15 starts in the morning. And so how is the anesthesiologist going to be in 4 places at once? So it's a little it's a little vague on how they're participating, right? So it doesn't clearly say that they necessarily have to physically be in the room. So a lot of times it's a verbal participation. You talk to your anesthesiologist, you tell them you're ready to start the case, and they may tell you go ahead, or they may physically want to be there. Some anesthesiologists want to be in all four starts, and they'll say don't do anything until I'm there. So just make sure that you communicate what the plan is for the induction, and then for emergence as well. And then it's also a little vague as far as what demanding anesthetic procedures are. Certainly if the patient, if something catastrophic happens, if the surgeon maybe accidentally nicks an artery and you're needing to give a massive blood transfusion, calcium, check labs, obviously you're going to need your anesthesia. You're going to need a second set of hands, right? So you're going to let your anesthesiologist know this is a demanding part of the case. But then again, sometimes anesthesiologists want to be aware that you're checking the hemoglobin because, you've lost 600 of blood, it's never a bad idea to keep your anesthesiologist informed, if there's been anything outside the norm, right? And then in addition to that, they should be checking for the medical direction model. They need to be checking in on routine intervals anyway. So another thing they need to do is ensure a qualified anesthesia provider performs any procedures that the MDA does not perform. And that's easy because you're performing all of the procedures that they're not performing. The next thing is to monitor the course of anesthesia at frequent intervals. So the ASA doesn't really define what frequent intervals are. So the anesthesia group may decide that it's every hour or every 30 minutes, or maybe it just depends on the type of case, but they'll need to check in, and they usually will notate on your chart that when they checked in so that they can meet the criteria for this billing method. Another thing is to monitor the course of anesthesia. Okay, I'm sorry. The next thing is to remain present for all critical portions of the procedure and available for the immediate diagnosis and treatment of medical emergencies. So that's very similar to what we were talking about, demanding anesthetic procedures, things where they need to be present for immediate emergencies. And then finally, they need to provide post-operative or post-anesthesia care as indicated. So after you're done with anesthesia, you take your patient to recovery, you give report to the PACU nurse, and you always tell the PACU nurse who the anesthesiologist that's covering that case. And that way, when you're rolling back with your next patient, the PACU nurse is going to call the anesthesiologist for orders or for concerns, because you're going to be tied up then with your next patient. So those are 7 criteria that need to be met in order for the MDA to bill for this model. All right. The next one is medical supervision. Medical supervision is very different. And it just basically requires that any physician can oversee an undefined number of anesthesia providers or CRNAs, right? And so there is no requirement for physician hands-on care with medical supervision, all right? And so what we see in the DFW area is that there's a lot of endoscopy centers and plastic surgery centers and places like that where there's only a CRNA, no MDA, and the medical director would be the endoscopist or the surgeon, all right? So any physician can can provide medical supervision according to this billing model. The concern here is that oftentimes, if not all the times in these situations, the surgeon or the endoscopist is not trained in anesthesia. So to the degree that are they supervising, what degree could they be supervising? And if you need a second set of hands, your surgeon's doing surgery, another CRNA could provide your second set of hands, or even a nurse that you've trained to help you in certain situations, if you needed to train a nurse to bag your patient while you're masking them and those kind of things. And so because of this, at this point in time, 25 states, of the United States and Washington, D.C. have opted out of medical supervision requirements on CRNAs for CMS billing, all right? So CMS billing stands for Center of Medicare and Medicaid Services, and this is government funded. And so this is basically what the government is willing to reimburse for. And so the government is willing to reimburse for medical supervision and allows states to opt out of requiring medical supervision. And if the state's representatives opt out of medical supervision, then CMS can reimburse the CRNA directly for providing anesthesia. And so that's where we're at now. And then, so then there's CRNA practices, right? So CRNA only practices in the settings that do not require medical supervision. The CRNA independently performs all aspects of the anesthetic and can bill it independently as QZ. And so the reason that this is important is government funding or CMS billing generally is the benchmark for which other commercial insurance companies follow suit with. So then the CRNA can bill any insurance company, typically as long as they're following suit with what CMS is reimbursing for, and typically they do. And you'll learn way more about that in your professional aspects class. But I wanted you to be aware of that because I know this is a conflict resolution lecture, but these are the kind of things that can get you in situations that you don't want to be in. You want to be compliant with whatever billing model your facility has chose to adopt. All right, so next is understanding anesthesia care models. All right, so again, you want to be aware of your facility's anesthesia practice model so that it's compliant with billing and we're not committing any billing fraud or facilitating that. The medical direction is the least CRNA autonomous model, right? And multiple criteria, as we said, has to be met, which can be very challenging and it can be inefficient. If you're going to keep your patient asleep for an extra 20 minutes waiting on an anesthesiologist to be there for the wake up, is that really the best for the patient and the best use of resources? So billing dilemmas can be common with this model. Start times may need to be staggered. Critical portions and procedures can end up coinciding, right? So happening at the same time. And then emergence times can also end up coinciding. And so this creates a little bit of a dilemma. So we need to be in constant communication with our anesthesiologist because at least that shows that you are trying to help them reach all of these 7 criteria for the billing and doing your part in that process. All right, so now we're going to break this into pre-op, inter-op, and post-op so that we can have an idea of what to expect and have effective communication in these areas. So in pre-op, you're going to introduce yourself to the patient and to their family. And when you introduce yourself, make sure that you tell them your name, your title, and exactly what you'll be doing. This is extremely important. Because the MDA is going to pre-op your patient, right, and provide you some information, but you're not going to get 100% of everything the patient conveyed to the anesthesiologist to you, right? So it's like a game of telephone. You really want to get as much direct information from the patient as possible. And you want the patient to know who you are. You want to build confidence in them, and you want to educate them on what your role is in this process. So you're also going to do a pre-op assessment on your patients. So you're going to ask them about all of their systems, again, because you may not get 100% of the information. You know, your patient may not be a diabetic, right? And so that may not be on the paper, but maybe they tell you, oh, I do have, you know, a creeping up A1C and I do have some pre-diabetes. And, you know, then maybe you might think about checking your blood sugar or think about maybe scaling back on your steroids, those kind of things. So some of those gray areas that you may not see in black and white on your pre-op, right? You're going to need to know how to do a pre-op assessment, a very thorough pre-op assessment, also because there's a good chance that you may be practicing independently whenever you get on the other end of this and you're a CRNA, right? So pre-op assessment is going to be looking at a head to toe, you know, assessment of the patient's history, what their physical status is, and you're going to go through all of their body systems. You know, do you have any history of seizures or strokes? Do you have diabetes, thyroid problems, cardiac problems, any breathing problems, liver problems, kidney problems? We're going to go through everything and get a thorough understanding of our patients. So even though your anesthesiologist has done this, you still need to do it. And it may be redundant, but you're going to be in the operating room with the patient and you need to fully understand their comorbidities and what to expect during the case. Additionally, you want to clarify your role. You want to make eye contact. You want to make them comfortable, make their experience as pleasant as possible. So smile at them, make eye contact. They're going to be nervous. They're here. They may be in pain, and nobody's excited about having surgery. So gentle humor, something to kind of just make them feel better about this process is going to resonate with them, and it's going to stick with them, right? So we're in charge of our patients' comfort in all aspects, okay? Also, on top of that, realize that every patient is going to get a satisfaction survey and they'll be asked to evaluate you and how you did, right? And so you don't want to be you don't want them to think. So what happens sometimes is the anesthesiologist introduces themselves to the patient and does their assessment, and they just say, "I'm the anesthesiologist," and the patient assumes that that's going to be the person giving their anesthesia, right? Because that's what it sounds like. And then you come in, and if you're not clear about your role, they just think you're just another person getting them back to the operating room and putting monitors on, and they don't understand it, right? So you need to be clear in what you're doing. I always say, if as a CRNA, I am a CRNA, I do anesthesia. I'll be the one giving you the medicines that put you to sleep. I'll be with you the entire time, making sure that you're safe and comfortable, watching your heart, watching your hemodynamics, managing you, waking you up at the end, and I'll make sure that you're safe the entire time. So they know clearly what I am, that I do anesthesia, and these are my responsibilities in doing the anesthesia. And so when they get the evaluation form, be aware of the kind of things that are going to be asked to them, because you want to make sure you check all the boxes appropriately. So some of the common things that are going to be asked is, did the CRNA clearly identify their role with you? And was the anesthetic technique that they're using clearly explained to you? So if you're going to do a block, was that explained? Any regional anesthesia, general anesthesia, how that works, the kind of things that may or may not happen, like, decent chance we're going to need to give you blood because your hemoglobin's low and this is kind of a high risk procedure, or those kind of things, right? And then make sure you give the patient an opportunity to ask questions to you, all right? Because you may feel like you kind of covered everything, but a patient may have some questions, and sometimes the questions aren't anesthesia related. Sometimes they're more surgical related or related to post-op care. But be available to answer questions or direct them to how they can attain the answers to the questions that they have. And then the evaluations are always going to say, was your comfort level ensured? And so be sure that you're providing comfort for them on every level possible. Now, before you leave pre-op, there's going to be a timeout process. All right. So a timeout with the pre-op nurse that got the patient ready and the circulator. It's going to go over consents. It's going to go over patient-specific things like allergies and was the right site located, the correct site marked, and those kind of things. And then before you leave, you're probably going to give Versed, unless they're an elderly patient or they have some contraindications to Versed. You're going to give Versed, but please, please, please always wipe the hub with alcohol before you give Versed. And I'll tell you, when I was pregnant, I was in the ER for like some nausea and vomiting and stuff like that. And the nurse gave me some medicine into my IV, and they didn't wipe it with alcohol. And I remember it just kind of was such a turn off, because I had been in and out of the bathroom all around that ER with my IV tube and just dragging around the place. And I thought that was so unprofessional. So I really want to convey that to you guys. Like, please always do everything. You don't know if your patient's a medical provider, if their family is or isn't. And regardless, your job is to provide optimal care for them. So please check even the small boxes to make sure that they feel comfortable with you and your professionalism. So circling back to that timeout process in pre-op. So these are the things that are generally addressed during timeout in pre-op, okay? So you guys are going to all get together with the patient's chart and reiterate that all of these things are correct. So what's the patient's name? What is their birthday? And the patient's going to participate in timeout as well. So if there's anything inaccurate, we ask them to speak up as well. What are their allergies? What is the procedure that they're having done? Who are their surgeon or surgeons that are going to be involved in the procedure? Was the correct site marked? This is so imperative that you guys pay attention to this, because there have been situations where the wrong leg has been marked, the wrong foot has been marked, and this would be so catastrophic for the patient and for you. It's not going to be good for you. You're going to have a lot of questions to answer if you participate in a timeout and the wrong site was marked and the wrong surgery was performed. So please don't let that happen. Again, you're going to review the consents that they were signed appropriately, both the anesthesia consent and the surgical consent. And in pre-op, you're going to address which pre-op antibiotics are going to be given. And this is going to need to correlate with what their allergies are. So if they're allergic to penicillin, they've had an anaphylactic reaction, you're not going to give Ansep. You're going to opt for something else. And we'll talk about that in our antibiotic lecture. but you're going to make sure appropriate antibiotics are ordered for the case. You're going to make sure that they've received a beta blocker if it's required, and it's usually required if the patient normally takes a beta blocker. So if the patient's on a beta blocker, they need to have it the morning of surgery, and that's a skip measure. And then does everyone agree, the circulator, the pre-op nurse, you, and the patient? And then we'll ask the patient if they have any specific concerns before we proceed. So then at this point, once the timeout is done, that's when you wipe the hub with alcohol and you give the Versed. And then you're off to surgery. Okay, so now we're moving on to intraoperative communication. All right, so we ensure our patient's comfort on the way back to the operating room. I always try to make a little conversation if the patient seems like they're nervous, ask them where they're from, ask them what they do, depending on how old they are, you just ask appropriate questions. And then once you get to the operating room, you're going to introduce them to the other staff members that are in the operating room. So the scrub techs, the nurses, any assistants, any students, just make sure that you introduce them, and that makes everybody more comfortable. And this is another way for you to establish who everybody is and get familiar with everybody in the operating room. Now, once you're in there, you're going to line that bed right up next to the operating room. So you're going to line the stretcher right up next to the operating room table. And we talked about this in our positioning lecture. Oftentimes we need full staff assist to move the patient to the operating table, especially if they have an injury or something and they're not really able to move themselves. Sometimes they can move themselves over. I prefer them to move themselves over if they don't have an injury, because that way we can ensure that they are they're going to be comfortable because they position themselves, right? But if not, then you and the team will move them over, and every movement happens on your count. So you make sure that the stretcher is locked, that the bed is locked, and there's somebody that has the feet and somebody on either side of the patient, and you have the head. So you'll want a smooth transition from the stretcher over to the operating room table. And so again, communication is important. And then sometimes this varies with your circulators. Some circulators are more aggressive. They want to put the oxygen on the patient's face. Airway is your department, so you let them know whether or not you're okay with that. Oftentimes, I like to balance the mask, turn the oxygen on, balance the mask on the patient's face with the tube caddy. I think I'm sure we talked about this in our positioning or in our induction sim lab. But the thing is, depending on the patient's reserve, you may not need a tight seal as long as you can just lay the mask on the patient's face. Some of these patients still have high anxiety. They get claustrophobic. If they have a high reserve and they're not likely to have any airway problems, you may just kind of loosely put it on their face or even give them a little blow by until they get more relaxed. You do want an oxygen seal as you're putting them to sleep and having them take deep, deep breaths to build up their reserve. So oxygen is obviously great, but you're gonna have to gauge your patient's tolerance and how aggressive you need to be with that. If they have OSA, if they're already desatting after you gave the Versed, sorry, you're gonna have a mask seal, and I'm gonna be the one to do it, not the circulator. But if your circulator, seems to be helpful and you want them to help you out in that department, that's completely on you. They're not all the same. Some circulators are really good at doing the mask, holding the mask and being helpful. And so you're just going to have to make that call based on who you're working with. All right, so then you're going to notify your anesthesiologist if you're in an ACT model, an anesthesia care team model, that you're ready to start the case. You're ready to put the patient to sleep. They may tell you to proceed. They may say, wait till I get there. Normally, the CRNA or the resident will push the induction drugs. However, that's not always the case. And when you don't know the people you're working with, communication is everything. So you ask, do you want me to proceed? Do you, find out what the plan is. And if you do ask them if they mind, do you mind if I go ahead? Be prepared for them to ask you, well, what doses are you going to give? Because they don't know you yet. They don't know that you know the correct doses. So make sure that you're prepared to answer that appropriately. You're going to learn the dynamic as you go. Always communicate. as a resident, you're going to want to place as many lines as possible. And so if your patient's going to have an ART line, then a second IV after you put him to sleep, you may intubate the patient and then ask the CRNA to tape the tube while you start the A line, so you can get really efficient in getting everything done in a timely manner. Because if the surgeon is waiting because it's taking, you're learning, it's going to take you a little bit longer, but you can condense some things that aren't critical, things like taping the tube, and maybe hand that off to somebody that can do that for you while you work on the things that you need to learn to do and become better at. And then you're going to move your patient into the position that's appropriate for the surgery. So you may be putting him in lithotomy, or you may be putting him on the side in a lateral position. So we've talked about all these different positioning techniques, but nobody is allowed to move your patient without talking to you first. So they don't need to be putting the patient in stirrups without talking to you. That's not allowed. That's not okay. And everybody in the operating room knows that. But sometimes they can get a little aggressive, and you need to make it clear that, you're in charge of making sure the patient's safe. You're the one that put them to sleep, and you need to prevent any possible injury. So if there's any movement or change in position, you need to be incorporated in that process. And so we talked about this also, but you count 1, 2, 3, and then everyone moves on 3 with all the position changes, even if it's just moving the patient down an inch or 2 in the bed. It's always something that needs to be managed by you at the head of the bed. Okay, so once you have the patient in position, the circulator is going to prep the patient. We're going to get ready to start surgery. And then there's another timeout, which is the surgical timeout that the surgeon is involved in. And so this is like a second layer of safety. So during that timeout, at the end of the timeout, the circulator will ask anesthesia. A lot of times they just say anesthesia, right? So then that that's your cue to indicate which antibiotics, if any, you're going to be given. And if you don't know, say they have an allergy to what was ordered, that's your cue to address it with the surgeon. What antibiotics are we giving? These are the allergies, and make sure that the appropriate antibiotics are given, and they need to be given in the appropriate time window. So you want to have them in 15 minutes before surgery. So oftentimes if we're about to start, you need to address this beforehand. But then this is the antibiotics the patient is giving or has already received. And then any other patient specific concerns, this is your time to address with the surgeon and everybody in the room, things like, this patient's already running a little bradycardic, heart rate's 55, we're going to be insufflating. I want to make sure that we go slow with the insufflation and maybe keep the pressures a little lower than normal, if that's possible, so that everybody knows what kind of things are on your radar so that they can accommodate, and you're not just, having to deal with things that could have been discussed and prevented. And then certain cases are going to require discussion with the surgeon about preferences and candidate specifics, right? So if you're doing, for instance, a DNC, you want to ask, are we giving Pitocin, and will you let me know when you'd like it to be given, and how much do you want? Do you want 20 units? Do you want 30 units? Make sure that you kind of are already prepared to do that. And that way, when the surgeon's ready for it, they just say Pitocin and and you don't ever want to have to be like, oh, I don't have it in the room. Let me call somebody for it. And then, the uterus isn't clamping down like it needs to. Because sometimes Pitocin isn't one that's always standardly stocked in every operating room. If you're doing a hysterectomy, a common drug is to give Toradol. But you will always want to ask your surgeon, are you going to be good with me giving Toradol, or do you have any objection to Toradol? Because some surgeons really don't like it. I mean, it's one of the drugs that it's very beneficial to get on board as an anti-inflammatory, and helps with pain control. But it also has some bleeding implications and things that the surgeon may have had a bad experience with Toradol before, right? So you want to make sure that they're okay with you giving it. Another situation would be in orthopedics. Oftentimes we give TXA. On the majority of our orthopedic cases, we give TXA, but again, make sure that that's something that your surgeon wants you to give. And then in neuro cases, we talked about this in assessment, you're going to need to address whether or not your patient needs additional steroids. And then is seizure prophylaxis indicated, right? So if you're going to be doing a cranie, especially with a supratentorial lesion, you want to tell the surgeon, this is the last time they had their Keppra or whatever anti-seizure medication. Do you want me to redose it? Do you want another, anti-seizure medication on board? And make sure that everybody's on the same page there. These are the kind of things that if not addressed and like say you didn't give anything, right, then it's going to come back to you. So make sure that you get ahead of it and address these things, these patient or surgery specific things at the beginning of the case. And that timeout is the perfect opportunity to do so. You always want to monitor and communicate blood loss as well throughout the case. This is very important. The surgeon wants to know, and your anesthesiologist needs to be on board, especially if it's a high blood loss case. And so if you're going to check a hemoglobin, say your hemoglobin started at 10, you checked it and it's 8, right? Tell the surgeon it's 8. If the surgeon thinks, look, we're about to have a lot more blood loss, you need to go ahead and start handling that appropriately, getting the blood in the room, getting ready to hang it, those kind of things. So just keep everybody on the same page with that. Communicate with the entire team when you're giving blood products. And blood products always require a dual check off to some, on some level of double verification before it's given. This is necessary, okay, because it can be catastrophic if you give the patient the wrong blood type. And we had a student years ago that was in a situation where the patient was bleeding heavily, needed blood immediately, and she just spiked it and hung it and didn't check it. And that was a big, big, big deal. So, it was caught, they checked it as it was infusing, but that went, there were several meetings about that because that would have been a huge sentinel event. So it doesn't matter how bad your patient's doing. It doesn't matter if you're coding and they're just bleeding out. You're going to check the blood every single time before you hang it. You can get very efficient, and there are processes to make it faster and faster because blood is one of those things that when you need it sometimes. And so there's scanning tools and things in certain facilities that have kind of expedited the process, but never just hang it. Never just hang blood without checking it. And then at the end of the case, you and the surgeon need to agree on EBL because both of you are going to chart a specific number and you need your charts to match, right? So sometimes there's disagreement about what was the blood loss during the case. The surgeon will typically ask you, what's EBL? And so that's kind of a loaded question because sometimes you're like, gosh, you were right there. I can tell you what I think, but why don't you? I always say, what do you think, right? Because if I'm thinking it was 50 and they are thinking it was 30, I'm okay either way as long as there wasn't any kind of hemodynamic change and, we can just document a number that we both agree on. But if there's a substantial difference and you are having to give blood and the hemoglobin dropped dramatically, you want to be a little bit more accurate in how much blood was lost. And that's whenever you're gonna take a close look at what and make sure, this is what I'm seeing and this is what I know to be true. And based on the numbers, this is, we lost 1,200 of blood. This is an area that's been, typically surgeons will, it doesn't make them look good, right, to have a whole lot of blood loss. And so you need accuracy and you need agreement, and that's the bottom line. And everybody will, everybody kind of knows that, but I just want you to document accurately. Don't be persuaded into documenting a lower number than because this is important for the patient's care as a whole, right? And then some surgeons at the end of the case want an IV fluid number. How much fluid did you give? Did you give 1,500? Did you give 1,700? What was their urine output? If they have a Foley catheter, they want a measured cc volume of urine documented, and what was the blood loss. They're always going to want blood loss. Some of them want all three numbers. So be prepared to give all three numbers so that they can document it and your documents match. All right, then finally, PACU communication, right? So once you roll into PACU, the first thing you're going to need to do is collect vital signs. You can't always count on the PACU nurse for being there and ready to hook the patient up. So if they're not right there, you hook the patient up to their monitors. And usually it's a two-man process. You're probably putting on the pulse ox while they're hooking up the blood pressure cuff and cycling it. But immediately vital signs are obtained upon arrival. And then it's time to give report. And so normally the circulator gives report first. So they will identify the patient, date, time, I'm sorry, their name, their date of birth, and look at their ID band, and then go through the report of the surgery and what surgery was performed and those kind of things, and how many incision sites there are, and then they'll look at them. And so while this is going on, the best use of your time is to start closing out your anesthesia record, right? Because they're talking, you're obtaining vital signs, and then a lot of times, if you're doing computer or paper charting, either way, start that process of putting in your final note, charting the vital signs as they are occurring. And that way, when your circulator is done, you give report and then you can move on, right? So when we give our anesthesia report, the things that we need to address, because the circulator doesn't really know what the patient was like before surgery, they're seeing them on the tail end where they're, still snockered from the anesthetic. Maybe they're in a little bit of pain, but they need to know what was their baseline mental status, that they can make sure that they, by the end of their PACU stay, are pretty much near their baseline status, right? And were there any baseline abnormalities? Like, did this patient require HOMO 2? Did they come in on a nasal cannula? Did they have any baseline arrhythmias? What was their baseline heart rate like? Did they have hypertension? Do they live with hypertension? What's their normal range of blood pressure? And then are they diabetic? And what was their most recent blood sugar? So those are things that the PACU nurse needs to know right off the bat. They need to know if the patient received any recent medications for pain and blood pressure, because if patient's kind of moany groany saying that they hurt a little, but you gave, morphine or fentanyl 10 minutes ago, maybe they're just still kind of haven't really felt the full effects of the medication that you gave them, right? So make sure that you tell them the last time that they received a medication for pain or for their blood pressure, so that they can use that information to guide their next steps. What was their total IV fluid in? What was the total estimated blood loss? What was their total narcotics that you gave during the procedure? Did they receive IV Tylenol? Because that's going to determine whether or not the PACU nurse can give it, or how long the window is before they can have Tylenol again. And then what antiemetics were given, because post-op nausea, vomiting is very common, and the recovery nurse needs to know what all is on board so that they can act accordingly and give the next most appropriate antiemetics. And then, of course, if this is an anesthesia care team model, they need to know which anesthesiologist to contact for further concerns or further orders. And then before you leave PACU, always, always, always ask your PACU nurse, are you good with everything? Are you happy? Because you don't want to just drop some information and run off. They may have questions, and that's just the way you complete the report, okay? And then finally, we're going to talk about effective communication skills, okay? So when we're talking about communication, there's verbal communication, which are the words that you're using. There's paraverbal communication, which is referring to the tone, the pitch, the speed of talking, those kind of things. And then there's nonverbal communication, which we'll get into as well. But all of these things are how we convey our messages. And so it's important that we are aware of how we're communicating so we can do a good job at that. So verbal communication refers to the tone and the tone and projection of your voice are very important. In the operating room especially, it can be difficult to hear you. You have a mask on. We can't rely on lip reading, right? Which I think we do more than we realize. And then in pre-op, a lot of times our patients are hard of hearing, and a lot of times we have to make them take their hearing aids out before we go back, and they're even harder of hearing. Realize that your verbal communication is going to have a couple of obstacles in the way, okay? In the operating room, there's oftentimes music, there's equipment that can be loud, you've got your monitor beeping, so you're gonna have to project your voice, and there may be multiple conversations going on. So if you need to convey a message, you're gonna have to make sure that you're heard, okay? So make eye contact, be direct in your speech, and always convey competence and respect when you're speaking. So for instance, again, when we're talking about whether or not the surgeon wants Toradol, you want to convey competence. So if you say, can I give Toradol? It may sound like you're unsure of yourself. Is that a good idea or not? But you can say, do you have any objection to Toradol? And that sounds like you're just taking that you're a team player and you're respecting your surgeon's input on that, and what their thoughts and feelings are on it. And then likewise, when you're talking to the nurse, instead of saying, can you start the IV? IV, which may sound like, are you capable? You can say, would you mind starting the IV? And that just, again, keeps them as a team player, and you're being respectful in your speech. Now, paraverbal communication, as I said, is going to refer more to things like the tone, the pitch, and the pace of your speech. All right, so realize that you're going to enter clinicals with a very solid, knowledge base from the didactic. You've been studying about this stuff now for over a year, right? So be confident in your practical understanding. The thing that you're lacking is clinical anesthesia experience at this point, right? So you need to immerse yourself in as many learning opportunities as possible so you can build up your clinical competence. That's going to make you more confident. That's going to make your team more confident in you. And it's going to build up your skills, and it's going to help patient safety. This is what you're here for. So obviously, take care of your patients, be prepared for your patients. But when you have time between cases and when you have downtime, because it happens, cases cancel, surgeons are late, you're going to find yourself with free time on your hands. And what will you do with that free time is noticed, and it's important. If you go to the break room and start snacking on snacks for an hour when there's an Accreta flying in and you could be another set of hands helping start IV, help charting, things like that, it goes noticed what kind of worker you are. And I know we're talking about paraverbal speech, but the way you communicate with your teammates is going to be important. You're lacking your clinical experience, so that's what you're here to try to obtain. Present yourself as ready to learn, to help, and implement what you can based on your level of experience. So if you've never done a block, if you've never done, I don't know, a central line, and this is an emergency case, this isn't really your time to learn. So yes, we want you to learn all of those things, but take into account the scenario that you're in so that you can act appropriate. You can always help on some level, even if it's bringing some extra supplies or giving report to the ICU. There's always something you can do. And then realize that likability and ease of communication are key features in avoiding conflict and building a positive reputation. So, this should all go without being said, but I just want to reiterate it for you guys. And then finally, nonverbal. So surprisingly, over 70% of communication is nonverbal. So it's not just what you're saying, it's your posture, your eye contact, how attentive your facial expression is, your body language, your gestures, all of these things go into the message that you're conveying. So carry yourself in a confident, very open and approachable manner. And then your nonverbal communication, your actions, your gestures all need to match your verbal communication so that it's all congruent and you're conveying the messages that you want to convey appropriately. Do you guys have any questions so far? Okay, so now we're going to move on. Dr. Cornelius is going to present the second half of this lecture for us.
Okay, guys, can you see my screen okay?
Yes.
Cool. Yeah. So we're going to talk about some real life examples, and this is kind of illustrating a lot of what Dr. Mordecai talked about as far as situations you're going to encounter. Some of these are not residency specific. You'll see that a lot of times these are just anesthesia issues we encounter, but by proxy, these will be directed at you as well. So this is one you guys might have seen in the ICU. Generally, when we're putting in central venous catheters, we try and make it as sterile as possible to reduce the infection risk. But you'll see that sometimes, and it could be a surgeon, could be an anesthesia provider, but they'll take a shortcut to try and do it faster, or they perceive that the hospital regulations or the guidelines are kind of unnecessary. So you've got an anesthesia provider that needs to be putting in a central line, and they get into a conflict with the OR nurse as far as doing it. This is not a good situation for anyone, especially the patient who has an increased risk for infection as a result of it. The other thing is, after this procedure is done, after this case is done, you're still going to have to work with this nurse. she's not necessarily creating the policy. She's just telling you this is what you're supposed to do. There's certainly times that, maybe an emergency dictates you have to take a shortcut, but this probably is not it. This is one that we have to argue a lot of times. Surgeons really just want to cut on their patients. So anything that gets in the way of that is generally perceived as a problem for them. So you've got a patient that's sick, they're hyperkalemic, they didn't go to dialysis. The surgeon just wants to do the case. They don't want their patient to die, but they also kind of want to get their agenda accomplished. So this is a pretty common one, maybe not this exact set of circumstances, but for whatever reason, the surgeon wants to go through and do the case, even though in the patient's best interest, they really know and we know the case shouldn't be done right now. This is another one that we see a lot of times, and I think orthopods are the worst about it. So if you haven't spent any time in the OR, I don't think orthopedic surgeons can do anything without their rep, and that goes from like cooking dinner to going to the gym and certainly operating. So what you'll see is that they come up with the latest and greatest technique. I just said bone cement here, but oftentimes it's a tool, and there's a standardized process for how these things have to be done, whether it's to ensure sterility, ensure that the patient or the hospital can receive payment for it. But you'll see surgeons oftentimes will take shortcuts to try and bring these things in. I've even seen them like pull something out of their pocket and try to put it on the surgical field, and then it turns into a big event between the OR nurse and the circulator, or the OR nurse and the scrub tech and the surgeon. So this is something else you guys will commonly see that happens. The next one's something Dr. Mordecai was talking about. You've got a patient who's clearly lost a liter of blood, and it turns into a conflict. One of the things we see very often now is that blood product administration is kind of heavily scrutinized by the hospital. Not everywhere, but most facilities. Like Dr. Mordecai was saying, talking about EBL, if it's 30 mLs, 50 mLs, that's not clinically significant. But if it gets to the point of being a liter, obviously, if it gets to that point, the patient's probably going to have some hemodynamic symptoms. And that's when it turns into kind of a little bit bigger of a deal. The surgeon's saying 50 mLs, and in reality, it's 1,000, plus the patient's clinically symptomatic. That's a big deal that we need to argue, obviously advocating for your patient. But the surgeon doesn't want you giving those blood products because now his case is going to be reviewed. And you will commonly see these are the same surgeons that have these issues. Most people can do a hysterectomy with no problems, but Dr. Whatever constantly has to have MTPs done on his hysterectomies. He's poking holes in bladders, stuff like that. So again, this is kind of a common conflict that we run into. The important thing for you to remember is that you've got to advocate for your patient. This is another one you see. Now, commonly this scenario happens at smaller facilities. If you're at a larger facility, it's not quite as big a deal because usually the surgeon stays in-house all the time. But this is a patient who's post-procedure. You believe they're bleeding into the abdomen. A lot of times we see this kind of take place in PACU. And, you're trying to manage the patient, you're resuscitating them, but ultimately what they need is to go back to the OR with that surgeon and have whatever's bleeding fixed. They don't want to come in, they don't want to deal with it, so you're spent kind of struggling through this, even though it's not in the patient's best interest. We're starting to see this happen more and more. For a long time, obstetricians were kind of little islands. You may have a couple folks in a practice, but usually they took care of their own thing. Now we're starting to see that they're becoming more and more popular, but they're also kind of sharing their coverage. So before, if I was the obstetrician, I saw you in my office, I delivered your baby, I did your C-section, I did everything. Now we're seeing that there's more of like a float system or an in-house call system. So it makes life a little bit more friendly for them because it was really a truly horrible life to be an obstetrician. But you're starting to see that there's kind of the standard obstetrician, and then you have like these celebrities or rock stars or people that really bring in a lot of money or they're famous for whatever reason. And with that in mind, they tend to have a little bit more pull for things. So what you'll see is to get their way, they tend to try and flex things. One of the big ones is doing stuff at weird hours. In a normal world, we should be doing the high-risk cases first thing in the morning, in the middle of the daytime when all the resources are available. But we're starting to see more and more often that these kind of fringe cases are being pushed to the night. They're being pushed to the weekend. Many facilities have adopted policies against doing high-risk elective cases on kind of off hours for those reasons. you don't have all those services available to you. There's limited people in the blood bank. You may not have multiple anesthesia providers. But this turns into a conflict between the anesthesia department and the surgeons pretty frequently for those reasons. So these are just kind of some examples, and we're going to drill through stuff a little bit more. So one of the biggest issues we run into in healthcare and in life in general is communication. And it can be as simple as, not talking to somebody, or on the other end of things, not wanting to talk to people. Some folks don't communicate what they're saying very well. You'll see that increasingly on a generational level that people prefer to text than talk. We laugh about the Facebook warriors that become very cavalier because they're willing to say anything when they text it, but then when they're standing face to face with somebody, we tend to struggle. We deal with a lot of very tense situations in the operating room. And, it's great if you can text somebody, but oftentimes we have to talk to them and say things that, we don't want to say or that are uncomfortable. So that's something hard for us to learn when we go through residency and move into our clinical practice, because it does make us uncomfortable. One of the big transition points is when you were in the ICU, you were almost seen as subordinate to the surgeon or the physician. And now you're going to be a peer. So you have to talk to people and kind of address things in a little bit different situation than what you had before. The OR is really at high risk for conflict because there's a whole lot of people that are kind of responsible for the same things, but it's not very clearly established sometimes. So for instance, you're doing a case and a patient codes. Who's responsible for resuscitating the patient? Usually it's us, but what if it's something of, say, for instance, a CV surgeon or a traumatic arrest? You may be medically managing the patient, trying to get them resuscitated, but at the same time, the surgeon's going to have to be surgically managing the patient. So those boundaries tend to be very gray. You also have multiple providers that are very responsible for the patient, but responsible for different aspects of their care. So just be careful with that and kind of work towards having clearly established responsibilities. Sometimes the facility steps in and establishes that for you, but not all the time. The other thing is it's a very complex, high-pressure work environment. Most operating rooms take care of very sick people. Surgery is essentially intentional trauma. They're cutting on something, they're making it bleed, they're stressing the patient. We do the same thing when we put them under anesthesia. It's like the ultimate stress test. So a lot of pressure there. The other thing is many facilities are financially dependent on the operating room or the surgery center for revenue. So anything that tends to affect those things can be difficult. From our side, as well as the surgical side and the operating room staff, obviously it's stressful. We just talked about that, but sleep deprivation itself tends to affect our ability to communicate, our ability to make good decisions. So it's important for us to be very well rested. I know that sounds like an easy thing for me to say, and you guys will see when you get to residency that extra sleep is really the first thing to go. But in a perfect world, you're getting 8 hours of sleep a night. As a result of all these things that happen, you tend to have ethical conflicts and conflicts of interest that may emerge. I'm trying to use product XY because the ortho rep that paid for my beach vacation is the one that's selling it. It may not be the greatest thing, but all of a sudden there's kind of these confusions among providers. So these are kind of some specific anesthesia related conflicts that we encounter, and these are fairly common. Big one, like I was touching on, postponement or cancellation of case. And this comes for a couple different reasons. Most of us are not canceling or postponing cases because it's time for us to get off work and we want to leave. There's usually medical reasons related to it. If not, your reputation will quickly follow you and probably help you find new employment. How we talk to people goes a long way. The other thing is, depending on our relationship with the surgeon, that also goes a long way. There are some people that just can't talk to each other, either because of how they communicate, past history, stressful encounters. So it may be better off to have somebody else break the bad news, if you will. On the other hand, you may be the person that everybody likes to talk to. They respect your opinion. They know you're a good provider. So they respect that you're saying, hey, this is probably not the time to do this case for reason X, Y, and Z. The other thing is when you get something you don't like to hear, a lot of times we only pay attention to part of the interaction. So for instance, Dr. Bob, I'm canceling your case because of Dr. Bob has already stopped listening. I'm canceling his case is all he heard. The patient's been asystole for 3 hours. I could operate though. So you see sometimes that happens and it can be kind of a stressful interaction. So when you're breaking news that may be kind of terse or bad, think a second to kind of frame how you're going to present this. Also, when you do it, have a solid argument. This is why I'm doing it. Don't present it based off of something somebody told you. If it's an issue with the patient, make sure you've seen the patient. Lots of times we'll run into situations where somebody is doing something based off of what they read or what they heard. And then when you actually go see the patient or examine them, you figure out that that's not the case. When you try to cancel a case based off of something somebody told you, you've immediately lost any sort of credibility with the surgeon because they're going to turn around and ask you questions. So you need to be ready to answer that. Other things that we run into problems with, changing the staff assignments. So, and I'll just use Dr. Mordecai and myself. She's getting ready to do an X lab. She had everything set up the way she wanted it. But now I'm doing the case and I don't use medication XYZ or I want a different blade. So she had told them they were ready to roll back, but now I'm doing the case because she went home at 5 o'clock, 7 o'clock, whatever, and I need to change something. Or I don't feel comfortable doing the case. So part of it is, as a department, we need to kind of have established guidelines and support each other. Obviously, we're not all the same person and we all think differently. But if we have big inconsistencies in our practice as a department, it tends to make us look poor. Other things that we run into, and Dr. Mordecai touched on this earlier, the staffing model causing delays in induction and emergence in a medical direction setting. We're seeing more and more practices that have gone away from billing medical direction because the reality is if you have 4 rooms going at the same time, you're probably committing fraud. And whether you mean to or not, you're going to be drug into that. So let's avoid having everything going at the same time if we can. So just be careful about how things are stacked. And a lot of these are system issues, not just individual issues, but these are things you're going to encounter. Haley, do you have a question?
Yeah, I think we're still on Dr. Mordecai's screen because, yeah, we're still on the conflict in the OR slide, real life examples.
Huh. Okay. I wonder where I'm sharing.
I
don't know
see
why-
the anesthesia related conflict slide on my
You
side.
do? Okay.
Yeah. I've experienced some lags though, so I don't know if it's just an internet connection or something. Haley.
Yeah, I don't know. I just see it's still Dr. Mordecai's screen on mine, so maybe I just need to. I don't know, but I'm following, so it's fine.
Okay. What are other folks seeing?
I see your slides, Dr. Cornelius.
Okay.
Yeah, I
cool.
see your slides.
All right. Who knows? I don't know why Teams is tripping today. That's so bizarre. I wonder if we can share like 2 screens at the same time. Let me see if I can fix it real quick.
Okay, I think I'm seeing yours now, or I don't know. I'm seeing something different now.
I just shared my screens and I closed out my lecture, so you should only, because I see Dr. Cornelius's screen. And so I'm sharing mine, so hopefully you see his now, if you were seeing what I was seeing.
Yeah, I see yours. I'm gonna see if I can take back over and maybe it'll work right now. Are you guys back on me now? Cool.
Yes.
Okay. Who knows? Gotta love computers. All right. So we're going to talk a little bit about some strategies to resolve conflicts in the operating room. A lot of us use this avoidance. Unfortunately, you can't run away from it in the operating room. Just because you don't like what somebody said to you or how they're acting, you can't take off and leave your patient. So avoidance doesn't necessarily work in the operating room. Now, there are some exceptions to that. One of the things you may see is that, Dr. Bob doesn't like working with me, so I trade out with somebody else to not do his case. So that may be my way of diffusing the conflict that I know is coming because I can kind of trade out with him. Another one is yielding, and this is basically where I realize I made a mistake. and just let them do what they were doing. The other part of yielding is that sometimes you realize it's probably not worth fighting over. Um, if you've ever been in a relationship, you know that sometimes you're right, but winning is going to be the wrong way to do it. So you may just kind of back off that situation because it's not that big of a deal. One of the examples of that is like talking about estimated blood loss. So he says it's 50, I say it's 30. That's fine. There's not a big deal with those 20 mLs. So I'll just let them kind of go their way. Collaboration is really the preferred approach. And what this really means is that we both present our cases and we kind of look for the win-win. So usually we wind up agreeing on things. And a big part of this is dependent on your relationship with the surgeon, or not necessarily just the surgeon, but everybody in the room, because they're all either going to like or hate you, or you're going to have little friends. If everybody in the room likes you, they tend to give you a little bit of grace for stuff. On a compromise, we both kind of take things as a trade-off. He accepts that he lost a liter of blood loss, but I realize the hemoglobin has only gone from 14 to 10, so I'm not going to transfuse the patient. So we both kind of make trade-offs there. And then there's the competition, which unfortunately doesn't really get us anywhere. So what we see here is that it's really somebody wins and somebody loses. And that doesn't help the situation at all, because now somebody's upset, somebody's ego just got a huge boost. So we try and really go for this middle ground, a little bit more of the collaboration. So how do we figure this out? It takes a couple of different steps. One of the biggest things is having an institution that lays out a culture that doesn't tolerate kind of bad behavior. If you go back, in some places it still exists, but if you go back 10, 20, 30 years, physicians and especially surgeons could basically walk on water and get whatever they wanted. I'm sure you guys have all seen physicians that acted poorly. We've seen nurses that acted poorly too, yelling, screaming, throwing stuff. At an institutional level, you have to recognize that you can't tolerate that, because it's not only bad, but it also opens your facility up to liability. Because you have a surgeon under your employment or that's contracted with you that's creating a hostile workplace. It's just a matter of one person throwing up the flag or going to HR or finding a lawyer. And now not only is the surgeon on the hook, but the facility is going to be on the hook. So a facility that builds a culture that really advocates for good conflict resolution and kind of equivalent standing throughout the facility really goes a long way. On a personal level, things you really need to do, think about conflicts and talk to people. And the talking to people is one of the hardest things for us as anesthesia providers. You'll see that people get really comfortable just throwing the drapes up and kind of sitting over there and ignoring everything that's going on. Even casual conversations start to build that rapport that goes a long way with everybody else in the room. And it doesn't have to be in the middle of the case, and certainly not in the middle of something bad happening. But if you get used to saying hi or introducing yourself to everybody in the morning, making sure you know folks' name, that goes quite a long way. Other things that are helpful, figure out where these conflicts are coming from. Every day I walk with Dr. Heather, we have this problem or that problem. Well, why is that happening? Well, because it's Friday when I work with Dr. Heather. She's tired at the end of the week. I'm tired. I'm cranky. I'm post-call. So if you can kind of start figuring out where these things are coming from, it helps you resolve them. Other things, really figure out your personal rules of conduct. What are your values? What are things you're willing to negotiate on, and or things that you're not willing to negotiate? The operating room is a very different world from a lot of where we've been before. Even if you've been in the operating room as a scrub tech or a circulator, now you're in a very different aspect of it. So you kind of have to set your boundaries and be willing to stick with them. As I was saying, as far as like an institutional standpoint, kind of figure out what your shared standards and goals are and stick to them. Share that, make sure everybody's on the same point. This next one is probably one of the hardest ones. Find a non-judgmental starting point for discussion. So when whatever is going on, whether we're canceling a case or a patient's bleeding, or I think they need a medication, you've got to kind of come into it with an open mind, because you know why you want to do something, but you may not understand why the surgeon doesn't want you to do it. So understand and support what you're doing, but don't be so set on it that you're not willing to listen to the other side of things. Sometimes things suck for everybody. we don't have an electronic medical record, or the cases are always delayed for the third case of the day, or we only have 2 GI scopes. Recognize those shared frustrations because it's annoying to you and it's annoying to everybody else. And a lot of times you can kind of bond and have common ground in those situations. This is one of the biggest ones. And when you start looking at personalities, you'll quickly find these people. But choose your battles wisely. It's almost like the little boy who cried wolf. If you throw up a red flag or you complain about everything that's always going on, people start to write you off. One of the biggest examples I can think of this, there was a CRNA, good CRNA, but she flagged almost every intubation she did as a difficult airway. If every intubation is a difficult airway, it's probably not the patient's, it's probably you. But what happened as a result of that is people began to discount her opinion because they didn't trust her. She threw up that red flag and said everybody was difficult. So just something to be cautious with. If you're going to have kind of a terse discussion, try and do it in public, or in private, excuse me. Because if you're in public, somebody's going to be embarrassed no matter what, whether it's because of the discussion or because somebody wins and somebody loses. So pull that person to the side if possible. Try not to have it in the middle of the operating room. If you do have to have this in the middle of the operating room, you can talk quietly about it. You don't have to yell and scream about it. Something else to think about is having a very low threshold for bringing in kind of a third party to arbitrate things. It may be another surgeon, it may be another anesthesia provider, it may be like the practice administrator, maybe it's a friend, just somebody else that can kind of referee, for lack of a better word. And then this is another one. I'm not saying run away from the case, but if you're in a situation where you're going to have conflict and you can't resolve the conflict, the best thing to do may be to transfer the patient care to somebody else. Dr. Mordecai loves working with Dr. Bob. I hate Dr. Bob, so we're just going to switch cases for that. There's nothing wrong with that. Now, it may not be an option for you. For instance, you're working in a solo practice and you're the only one there. You're going to have to figure out how to work with Dr. Bob. These are a lot of barriers to communication, and you might see these again. But the biggest ones we run into are kind of the us factors. So our values, our beliefs, our differences, how we prepare and interpret things. Some of those come from your upbringing. Some of those come from your training. Some of them come from your personal experiences. So these are really the things that tend to cause us problems when we look at how we communicate and how we collaborate with people. Some of those things can be changed. Some of those can't. I would love to say that everybody is an equal opportunity offender in the operating room, but you will see that oftentimes there's discrimination that happens. You know, I get along with somebody great and they hate Dr. Mordecai. It's not because of anything that we can change, but that just happens. Sometimes you can kind of minimize some of those things. Sometimes you can't. So one of the things that, and I talked about this earlier, that we've kind of seen that's gone by the wayside, but does still happen, is aggressive behaviors. Sometimes there's reasons for it. We talked about it earlier that the operating room is a very high stress, high pressure environment. And you may see that sometimes people don't communicate the intensity of an action. So for instance, they need an instrument to stop the patient from bleeding to death. Some folks are pretty monotone when they ask for things. So they ask for, stapler XYZ, and, the nurse is kind of meandering around getting it. You may notice that they start to become aggressive. They may yell, they may scream. This is sometimes where we see things like being thrown or people screaming. If they had just clearly explained at the beginning, hey, I'm losing a lot of blood here, I need you to go get this stapler for me, the nurse would understand the situation a little bit better. So just kind of be careful about how you communicate things, and then don't get mad if you didn't communicate your expectations clearly to start off with. So how do we de-escalate some of these situations? Stay calm is a big one. Be respectful. We deal with a lot of chaotic situations. Chaos and resuscitation is really our business. So if you panic or you scream, or you lose control of yourself, the rest of the room's really going to follow that tone. So stay calm in the situation. Remember, it's not your emergency, it's the patient's. Think about your posture when you're talking to people. Some of us wave our hands around when we talk. Some people try and skip that by crossing their arms and holding stills. When you have your arms crossed, it's not a welcoming posture. A lot of times people see that, or like your hands on your hip as you're scolding someone. Think about the tone of your voice and how you're saying things and what you're saying. Many of us get nervous and have like these rambling periods that don't make any sense. So try and break that up, almost the opposite of proper grammar, where you're doing incomplete sentences. Say very short, clear things that make sure they understand what you're conveying. Think about how you're looking at people. Some of us have like resting bitch face, or our face gives away the expression. If you're talking to somebody and you're rolling your eyes, when you've got a mask on, they can't see your hair, they can't see your face, but all they see is your eyes twirling around there. Not a good look when you're trying to have a realistic conversation. On the other hand, the other thing that mask does is cover up your facial expressions. So, you're saying something and you're laughing or smiling, but they can't see that because you have that mask on. So realize that some of those things may not convey exactly what you're saying. This is a big one in the operating room, and it's something that people struggle with. Timing. You've got to wait for the right time to say things. Sometimes, in the middle of that critical case, the patient's bleeding out, they're trying to get the stapler. That's not the time to ask if the surgeon wants Toradol. That's not the time to ask if you should redose the antibiotics. So kind of read the room for some of these encounters. Think about how you're doing things and when you're doing things. When you're talking to somebody, stand up and look at them. Don't sit there and play on the computer or your phone while you're trying to have a conversation, because that means to them this is probably not real important. Other things to think about: if you're trying to get information, ask open-ended questions, let them provide the feedback. On the other hand, if it's something you just need a very clear answer on, a yes or no, give them two choices. If they're already mad, realize that and kind of acknowledge that, but also stress the importance of your issue and kind of why you've interrupted them with whatever's going on. Make sure, as I was saying, you give them kind of a clear message and that you're trying to help them out with whatever that's going on. And think about other solutions and choices. This is one of those things that sometimes we come in because this is what we always do, but they may have a different perspective for some reason. So be willing to kind of explore other options. So when we start talking about communications, there's some things we really need to think about. Why are we communicating? The big thing is to coordinate actions and information exchange. But sometimes it's to facilitate relationships. There's no reason we have to talk about football games in the middle of surgery, but sometimes it's to get to that good peer-to-peer threshold that we're trying to achieve. So realize that communication doesn't necessarily have to be work focused. Sometimes it can be kind of establishing a good level with that person. Things to think about and make sure you're including in your message, and this is where we really get into trouble for those of us that ramble or don't say things. The content, what you're saying as far as like self-revelation. So, why am I saying this? The relationship between the two of us, and then why I need them to say something. Hey, I realize you need the stapler because your patient's bleeding to death, but would you like me to give some TXA because that may help with hemorrhage control? A lot of times that kind of brings them in when you provide them a very specific appeal for their need. These are some like dysfunctional things that we do, and we've all done these things before. I can guarantee you've been in a code, or even like something as simple as cooking dinner, or hey, could somebody empty the dishwasher? Somebody doesn't live in your house, they're not going to empty the dishwasher. You're going to have to pick out specific individuals to do things, because otherwise nobody's going to accept responsibility for stuff. Poor speech patterns, and I'm probably the worst about this, especially first thing in the morning. I don't wake up till like 9 or 10 o'clock really. So first thing in the morning, I mutter. A lot of times my mind runs faster than my mouth, so I'll say things that don't quite make sense. Unfortunately or fortunately, depending on how you look at it, sometimes we have thick accents, or we talk very softly, we talk very loudly. So you've got to work on kind of making sure you have clear voice as well. Whether it's, singing to yourself on the way to work to make sure that you're awake or you're not stumbling over your words, whatever you have to do. Other things that cause problems, like I was saying, a lot of times my mind goes faster than my mouth. So I will throw out lots of information very quickly, and I don't pause other than take a breath. And if you're kind of that rambling person, it's very hard for people to follow what you're conveying to them. On the other hand, we have people that give you too little information. Hey, your patient needs something. Can I give him TXA? All right, well, why does the patient need TXA? because I didn't provide any sort of explanation. They don't know what's going on. The other thing you'll see is people that don't answer questions. And I'm sure you guys have all encountered this before. You ask somebody something, and instead of answering, they just kind of look around like, are you talking to me? That's frustrating. It's poor communication. Awkward silence is also a bad one, especially like when you ask somebody that question and then they just stand there and pause. So try and avoid doing that if you can. When you're talking to people, think about the tone of your voice and your timing again. You want to be assertive, but not aggressive. I want to make sure they understand what's going on, but I'm not angry at them. I'm not mad. I'm just trying to convey what's going on as far as this patient situation. And this is one that we really run into problems with. Everybody thinks they're the most important person in the world. We have this habit of interrupting people, debating, tuning them out, ignoring what's going on. Sometimes we respond with aggression. We've got to listen to both sides of an argument. We can't just go ahead and make up our own decisions. So these are some good communication patterns. And Dr. Mordecai talked about like verbal and paraverbal and nonverbal before. Big things, be very clear about what you're saying and who you're talking to. Make sure when you say something, you have a sender and a receiver. So especially for very high risk things like some of our medications, heparin and protamine specifically, Dr. Bob wants me to give 30,000 units of heparin. Okay, verifying I'm going to give 30,000 units of heparin now. And then when I do it to close that loop, I've given 30,000 units of heparin. That way we all know not only what the instructions were, but we've had clarity, and he also knows on his end that it's been done. Some of those things can be extremely devastating to patients like heparin and protamine, for example. Other things to think about, make sure everybody on the team is on the same page. Usually we do this in kind of that pre-op huddle, that pre-op checklist. So that way, if something happens, we kind of have an immediate action plan developed. Hey, patient's hemoglobin is 8. We've got 2 units of blood that's in the refrigerator. If we start having bleeding, I need somebody to go get it. And then you're going to specify who that somebody is, so you have very detailed communication. But if everybody knows kind of where we're starting at, it makes life a little bit easier when something happens. The OR is a team, but sometimes it's a very dysfunctional team. So be careful with your environment. Little things like we were saying, getting to know the folks you're working with go a long way. Big part of that is respect and communication for everyone else. Healthcare has traditionally done a very poor job of team building. If you look at stuff like the military or aviation, they do a really good job. And you don't have to like the people you're working with, but you do have to work with them. Sometimes you will see this is related to the facility. If you talk to folks that have been working for some time, they can tell you hospitals that were toxic, for lack of a better word. And I know you guys saw this in the ICU. You know, everybody loved working in the MICU, but if something happened and you had to float over to the respiratory ICU, nobody liked it. It was a toxic culture. The people that were there didn't even like each other. So those cultural issues can cause a lot of problems for you. So these are kind of 6 effective communication components. Situational awareness, and this is one of the hardest things for people to develop because you can't teach situational awareness. And like Dr. Mordecai was saying, when you first start off, the expectations are very low. You don't understand the culture in the operating room. You're still trying to figure out where to park and, you know, how to badge in. So over time, you'll develop this situational awareness. And as a nice part of that, it lets you kind of back off some of the other things. In the meantime, developing this situational awareness will be one of the most exhausting things you do. Problem identification. Everybody has to be willing to talk. One of the big things that we see in the operating room is somebody's about to make a mistake and more than one person or at least one person in the room knew it. For instance, somebody's getting ready to do surgery on the wrong leg. The scrub tech knows that's the wrong leg, but doesn't want to say anything because the surgeon's really important or she's new here. You have to be comfortable with speaking up. Decision making. Everybody has to be willing to act on the information they're getting. So for whatever reason, you've got to figure out the information coming in and then take your action. Distribution of workload is another one. Everybody in the room tends to feel like they have to do everything. We're very poor about delegating stuff. Think about the tasks that don't require your level of expertise. And the other part is if you need help, get help coming. Nobody wants to be the only one doing chest compressions or working in code. Find all your friends. Time management tends to go back to situational awareness. You'll see when you get to the OR that you have to do multiple things at the same time. For example, you're set up for your first case. Now you're in the middle of your first case, but as you're managing that patient, you also have to be getting everything ready for your next case. So what you'll see is you're trying to do two things at the same time, but because of your poor situational awareness, you're not able to keep an eye on the patient. So don't let your time management cause problems for your situational awareness. And then, like I said, it takes quite a while to get to that point. And then understanding how to resolve conflicts, listening, acknowledge feelings, and kind of building relationships. If you have somebody that's a successful team player, they can do a lot of things. They're very active, they listen, they know the questions to ask. They have an opinion, but they don't always have to share it. I'm sure we've all run into those oversharers, and they can be exhausting for us. You know the values and qualities of other team members. We've got a nurse in the OR at JPS that's amazing at starting IVs. Maybe I'm having a bad IV day. So, hey, Nick, come stick this patient for me. When you start thinking about things you need to do to accomplish the task at hand, keep to kind of what you need to do to accomplish that. So we're going to agree that this is what needs to happen. Nick needs to come start the IV because I can't do it. You also have to be critical of yourself and willing to accept any sort of feedback you get from folks. This is a hard part for us, and you'll see the further you go in school, the harder it's going to be. Early on, you're willing to listen to lots of critique, but usually by about the time you've got like 3 or 4 months left, you kind of feel like you know everything at that point. And you may. And I will be honest, you're going to run into situations where you're probably smarter than the preceptor you're working with. We all know those people, but the unfortunate reality is that you still have to accept their feedback and critique. We take something away from every anesthetic we do. It may be like, man, this was awesome. I'm going to do this on every case. Or it may be, this is horrible. I'm never doing that again. But you have to be willing to accept that feedback so you can kind of solve things in a constructive way. When we're put under pressure, which happens a lot in the operating room, we stop listening to folks. It's not only a physiologic principle with auditory exclusion, but there's also a social principle, and then there's the noise factor. So when we become stressed, we develop tunnel vision, our ears shut down, we don't listen anymore. But we also have factors that come into play in the operating room, like loud music, lots of people talking. Back to that, everybody thinks they're important. Nobody can hear if we're all yelling, so use that calm voice. We tend to do a poor job of reflecting on the actual problem at hand and tend to do kind of fringe activities. So stop and think about what's really going on here and where you want to go. The patient's bleeding from their AV fistula that's torn. Okay, we want to stop the bleeding. We want to put a tourniquet on. Those are little things to think about. It seems very basic, but a lot of times when we lose that communication, we're not able to accomplish those things. Something else that we see is that because of kind of the shared governance in the operating room, that we make a whole lot of decisions that make no decisions. So no one sees themselves as actually responsible for the patient. And I think anesthesia providers tend to be extremely poor about this. We're like, well, I'm just here to do the anesthesia. It's the surgeon's patient. Meanwhile, the surgeon assumes that we're managing the patient. So just think about where the risk actually lies and who's responsible for making that decision. The next thing we run into is conflicts with families. One of the big things that we have is back to failure to communicate. So we don't communicate what's going on. They don't understand. So think about kind of situations that are common to us. Your loved one's going in to have thoracic surgery and XLAP done. They're going to go to the ICU and stay intubated. Well, they didn't understand that when we said the patient's going to go upstairs or they're going to stay on the ventilator, that they were still going to have that tube in their mouth. So as a result of that, they tend to get upset. There's misunderstandings. We differ over kind of what's going on there. So we want the patient to be pain-free. Pain-free in our mind means manageable pain. When we said pain-free to them, they were thinking that was a 0. So kind of having clear boundaries and kind of goals for what we're setting up here. Something else we encounter is distrust. You know, they've had anesthesia providers in the past that were problematic or didn't do the best job. You have to overcome that. And that can be very difficult to do. Another issue we run into is kind of cultural bias or different values. We see a lot of times in obstetrics that maybe they don't want to have a male provider. Okay, well, I want you to have an epidural, but I'm the only provider here tonight. How does that work out? And it's perfectly fine. We have to accept their input, but we also can't change some of those facts. So how do we manage these conflicts with families? And it's fairly similar to what we see with surgeons with kind of a little more specific things. So first, start off listening. A lot of times we come in with kind of a pre-designed agenda and timetable. I've got 2 minutes to get out here and pre-op the patient, get them consented, and go. And I go in there, and instead, the family's asking 50 questions. They're mad about something. So let's think about how we say things. One of the big ones is putting it on them, even if they're the one that's responsible for it. So we try and avoid saying things like, "Why are you angry?" And instead, I understand what's going on here. I hear what you're saying. Those sorts of things tend to be less confrontational. Um, Other things, we make mistakes or don't communicate things well. You'll see, especially if something bad happens in the operating room, one of the best things you can do is go out and sit there and provide your explanation and your point of view to the family. Another thing anesthesia providers are really bad about, nobody ever sees us. Like Dr. Mordecai said this morning, sometimes they'll see the physician in pre-op, sometimes they see the CRNA in pre-op. They don't understand who's what and who's doing different roles and responsibilities. So kind of make sure that everybody understands what's going on and that there's a clear delineation of how things are going to be done. And then when things don't go the way they're supposed to, go out and explain things. Oftentimes they understand what's going on. Um, if we put ourselves in that same situation, we can see why they'd be upset, why they're frustrated. I didn't communicate that when I did this nerve block that you weren't going to be able to move your arm, and now you're mad you can't move your arm. I can see how that's frustrating. Another one is apologizing. If you go look at a lot of the lawsuits, there are people that just want financial damages, but most folks want two things. They want somebody to accept responsibility and somebody to say they're sorry for what happened. And this is what comes from them, that time where we don't go talk to people. If we don't talk to them, we can't apologize for that action. Another thing that causes problems for us is that we tend to work as little islands. The surgeon's doing his thing, anesthesia is doing theirs. So we may talk to the family individually, but we don't explain things together. So a lot of these times you're better off going out and meeting with them as a team. I'm not saying you have to take the circulator and the scrub tech and everybody else in the universe, but you and the surgeon should probably sit down and discuss what happened together. If you do it individually, there tends to be a lot of blame and confusion and misinformation. And then ultimately respect them, thank them for what they're doing, and you'll see that a lot of times they appreciate you taking a minute or two to sit down with them. So we run into some specific problems as anesthesia providers. One of the biggest things is, and there are exceptions, but we don't tend to have long-term relationships with these patients. We've all had patients that were in the hospital and they made multiple trips to the operating room, but it's not like we're their PCP or their surgeon or somebody that they've seen 5 or 6 times in clinic before they got here. As a result of that, we tend to be the easy one to blame. Something else we see is that perception equals reality. Sometimes they have unrealistic expectations or desires for things. Hey, I realize you just had your whole sternum split open. You're probably going to be a little uncomfortable. I can't make you 100% pain-free. So getting them to understand that goes a long way. But part of that is us sitting down and talking to them, making sure they truly understand what's going on. Things you can do to kind of help out, especially if there's been tension or issues with that family. See if there's any sort of common ground. Is there a provider that they've done well with? Dr. Mordecai has done their case the last four times. She's got a great relationship with them. They don't like me because I'm a guy, I talk funny, whatever. Sometimes switching will be a good solution. You can also have that person talk to them. Just briefly say, hey, this is Dr. Cornelius. He's going to be doing your anesthesia today. And just that little introduction goes a very long way. If that doesn't work, you may have to go for kind of somebody on the hospital side that can mediate. The chaplain service tends to go a very long way with this. You may also be able to use something like the social services, the ombudsman. A lot of times we have patient advocates in the hospital. That may be something, or maybe even just the patient's nurse comes out and talks to them. Those can go quite a long way. And I'm going to finish up a little video here for you. which unfortunately shares a lot of the frustrations that we encounter in the operating room. Is that video playing for you guys?
No.
Let me find the right screen. Please hold. There we go. No, it's just a white screen. That's even worse.
Oh, morning. Wait, anesthesia, this patient got pre-op late. I haven't even checked him in yet. So, well, I need to get back by the 7:30 start. So we need to all work together here. I'm gonna have to start an IV while you check him in, okay? Oh, no, she didn't. Hey, Mr. Johnson.
Hi.
My name's Dr. Ermitz. I'm one of the anesthesia residents. We're
Nice
all
to meet
gonna
you.
work here together so we can get you back to the OR as quickly as we can, okay? I'm gonna start an IV while she gets to bed and checks you in.
Okay.
Hope you brought some things today.
Oh, it's hard to get an IV on me.
Hey, Mr. Johnson. You ready for your surgery? Anesthesia, we ready to go yet?
No, we're not ready to go yet.
Well, what's the holdup? It's 7:25. We gotta be operating in 5 minutes.
When the patient shows up at 7:20, I can't make magic happen. He needs an IV and he's also gonna need an A-line before we go back to the operating room.
And A-line, it's not like this case is gonna take like 8 hours or something like that.
What was his sugar this morning? His acne check was 280 this morning. So we need an A-line. We need to take frequent samples and we need to start a good IV on him.
This is not the way that a hospital should run. This is late, and I won't stand for it. Get him back by 7:30.
Excuse me, you need to mark your patient before you leave the area. All right, Mr. Johnson, here's some relaxation.
So this is funny, but it's not funny. This happens on a regular basis, and you guys will see how frustrating that can be. So just keep that in mind. There's a couple different ways we can kind of work through this.
It makes me feel a little better. Okay? Just keep your arm straight for me. All right. Feel good medicine coming your way. See, I told you I was good.
Well, let's go.
Control. Spent. Late. Control. Consent. Late. Healthcare providers, listen up. You're an anesthesiologist. Your patient is running late. It's a quarter past 8. Not even check for surgery. The pre-op nurse has got to the surgeon's mad room. Your patient is starting to get irate. What you gonna do? Fight or collaborate? Then master says to fighting yourself. You got to master yourself. With no help, stay calm, still centered and empowered. Putting others up on the shelf for higher. Open up your mind, eyes, and your ear. Be sure to look and listen. Don't just sit and hear. Control, gain absolute and total self-control. Consent, construct a consent zone. Link, click inside the consent zone. Lead inside the consent zone. Create a bulletproof argument by supporting it with 3 points, like shooting the winning 3-point. Remember this here, and your career will be here. How you gonna win the argument? You gotta construct the zone of consent. No bullying, accusing, judging, or berating. Be sincere, enthusiastic, and show that you're appreciative to your co-workers' thoughts and ability. Manage her emotions, finesse that hostility, cause you gotta keep it real. You argument don't take you to a new appeal. Now you're being seen in that good trustworthy. Things are starting to feel right every morning. Feeling your powers and feelings after yawning. Since dawning, please don't give up on it. Control, gain absolute and total self-control. Consent, construct a consent zone. Link, click inside the consent zone. Lead inside the consent zone. Create a bulletproof argument by supporting it with 3 points. By shooting the winning 3-point. Remember this here. And your career will be here.
Dr. Irvin. I know it's 7:20, so if you don't mind, we can take him in at the same time and get him ready. That sounds fine with me. Hey, Mr. Johnson, I'm Dr. Irvin. I'm one of the anesthesia residents. I'll be helping take care of you today.
Nice to meet you.
Let's see if you brought any veins with you.
Hey, Mr. Johnson, good to see you again.
Morning.
Anesthesia, we ready to go back?
No, sir. Unfortunately, we're not ready to go back. Mr. Johnson arrived late to the pre-op holding area, so he still needs an IV. And
It's 7:25.
I appreciate that. I believe he also needs an arterial line before we go back. His blood sugar is 280.
Look, this case is not gonna take 8 hours or anything like that. He doesn't need an A line. I want to be operating at 7:30.
We'll do our best. Oh, Dr. Garcia, would you mind coming back and marking the patient, please?
Later.
Are you having a hard time getting an IV or is everything okay?
I'm not seeing very good veins here, and I'm afraid if I stick him, I'm gonna blow it.
All right, we got an IV. Patient's marked. Let's go.
I agree with you, Dr. Garcia. We'll try to get back as quickly as we
I
can.
gotta see my family.
Your son's here. Family.
Hey, glad you made it. Yeah, how are you? Thought I got lost there for a while.
Look, this is really, I can't handle this. I gotta be operating at 7:30. You guys would never make it in private practice. That's all I gotta say.
Sorry about that.
Yeah,
We'll give you guys- we will take very good care of
I
you.
have.
I'll give you a little prize,
Crazy.
okay?
Crazy.
And then we'll head on back to the office.
Go.
We're hurrying, Dr. Garcia.
So kind of funny, kind of not. You guys will see that a lot of this is played out every day in operating rooms across the country. It's gotten better than it used to be because a lot of the processes have kind of changed. But this is what you're going to see when you get to clinicals. Maybe a little amplified, but that's okay. So just to follow up on questions, if you want to go through and have a class on how to drop seat beats, you're going to have to go through and do your own class and your own video, but feel free. So that's about to wrap up for the day. Do you guys have any questions about anything? I want to
All right, please.
apologize.
Or sorry, I was just gonna say, please reach out, and we do have an article posted that we need you guys to read and be familiar with as well. So please don't forget about that.
I wanted to reach out to a couple people because I think Dr. Castillo told you guys the wrong schedule. Class will be from 9 to 11. So if I sent you a text message, I apologize. You got misinformed. That's it. We'll see you guys on Tuesday.
Thank you.
Bye.
Thank you.